Okay. Good afternoon. I'm James Patterson. I help lead the transition to care use case within the PACIO project. And today we're working with folks from Actual Meds on our medication action plan vignette. This vignette is, again, using our common patient, Betsy Smith Johnson. She is a 74-year-old retiree that lives in Detroit. She has an extensive medical history across many different problems, issues including hypertension, cataracts, ischemic heart disease, type 2 diabetes, breast cancer, depression, and bipolar disorder, bipolar 1. That is means she has an extensive list of medications and things of that nature. So we'll be looking into those as we go through this upcoming situation, which is that Betsy is being discharged from the emergency department where she's being seen for an ischemic stroke. In this scenario, she is being transferred to a skilled nursing facility where she'll be receiving rehabilitation services. The vignette is going to include the ED sending the discharge notification to the skilled nursing facility, and that will include a transition of care bundle. That transition of care bundle will be received by the ED and also shared over to the medication reconciliation solution for review by the pharmacist for complete medication reconciliation workup. That medication reconciliation workup will result in a medication action plan facilitated by the PACIO SMPIG. And then that medication action plan will be transmitted back to the skilled nursing facility for use by that physician to determine best way forward on medications. The grayed out portion between the ED and the skilled nursing facility is provided by data that's already pre-positioned into the server. And then the skilled nursing facility but that transition care bundle is created on the fly during today's demonstration, as well as the discharge notification. The vignette, here's the vignette in another view. The actual transactions as they cross between the different servers, beginning with the discharge notification being sent across. The transition of care bundle, important to note that it does include the standard medication profile bundle, and then the work as described between the skilled nursing facility and the medication reconciliation solution provider includes those exchanges of the TOC data, including the SMP bundle, parsing that, and then doing their reconciliation and providing the information back. I think that concludes the introductory part, so I'll hand it over to you, Anne-Marie, for your discussion.
So by way of introducing Actual Meds is a best-in-class turnkey software and services organization that provides medication reconciliation use cases to a variety of different client types, including payers, plans, long-term care networks, managed care organizations, supporting a wide variety of use cases, including transitions of care, for example, with out of acute to long-term care or any other care transition modality, includes adherence management, medication risk management, special programs for disease verticals such as chronic kidney disease, and a variety of other use cases where deep dive medication reconciliation that's conducted either by clinical pharmacists within the organization that licenses our software as a SaaS solution, or via our SaaS partnered with our pharmacist on demand as a turnkey solution for deep dive medication reconciliations. These are, again, for complex patients, multiple diseases, multiple conditions, high degrees of complexity, or under some form of intensive management or a critical inflection point in the care continuum. So given that, we've been working with PACIO Group now for a couple of years, participating in these Connectathons. And our software is built on a foundation of interoperability where we ingest large quantities of data that can come in from a variety of different sources. We can get direct feeds from a PBM or payer in terms of claims and or eligibility that populates a patient roster. We can integrate to an EHR, HIEs, or the aggregators, in which case this is where we're currently doing the most with our FHIR API integrations. And what we can do is ingest large quantities of that data, contextualize and harmonize across a variety of different coding schemas, scrub that data to make it AI/automation friendly for our smart risk rules assessment engine and for our process automation mechanism. We can also take in a feed from SureScripts. We are a SureScripts certified partner for real-time claim and fill data. What we're doing is we're taking multiple different data sets, contextualizing it, and then harmonizing across all these different schemas. How this is meaningful to what we're doing with the FHIR ecosystem is we're maintaining provenance, we're maintaining full context, and we're layering context for the different medications based on what's available. We all know that healthcare data can be lossy in terms of both availability of data, but also how fully populated the data may be with any given feed. So we are filling that information in, and then automating large parts of the medication reconciliation process, letting pharmacists be pharmacists, taking away data curation and documentation steps, supporting intelligent assessment with the risk rules engine that can include all the way from the sort of baseline table stakes, drug interaction, duplication of therapy, but can go on to support quality measures such as STARS measures, other quality measures, or specialty protocols such as Beers rules for elderly patients, anticholinergic risk burden for fall avoidance, chronic kidney disease, formulary hospice, what have you. The automation of documentation allows for outputs that can be sent in a variety of formats. We can send the human readable PDF for things like e-faxing for those organizations to still operate on those channels. But more excitingly, we can send our information back as a FHIR transaction that includes complex bundle. As we saw in the previous slides, we can encapsulate not only sort of key patient demographics, encounter metadata, but we're using the standard medication profile in that bundle to put together a highly qualified medication list. And most excitingly, in our most recent work with the PACIO group and for this Connectathon has been to really push the boundaries of defining the medication action plan. We've been operating with medication action plans with a high degree of detail, which you'll see in the demo, for a while, but pushing the boundaries of what the implementation guide can define for structured information about what is an actionable item, what are the associated interventions associated with it, what are the recommendations, etc. And so providing nuance and richness to the action plan as a specific pharmacist-centered intervention. And of course, all of that data is available for analytics and reporting. And we look forward to where we can go with FHIR interfaces to support that as well for population health or population analysis. So with that, why don't we pivot over to the demo?
Great. Thanks very much, Anne-Marie. I'm going to go
Thanks,
ahead and
Pete.
share my screen. Okay. So to reiterate, in this test vignette, we're going to be demonstrating the packaging, retrieval, and transformation of medication data using the PACIO Standardized Medication Profile IG. And again, one of the things we'll be highlighting is the medication action plan, which is currently being developed and refined for inclusion in that IG. As mentioned, the synthetic patient who we'll be using for today's demonstration is Betsy Smith Johnson. She's being transferred from an emergency department where she's being seen for a stroke to a skilled nursing facility where she's going to be receiving rehabilitation services. And as part of Betsy's transition, the information is going to be sent via a transitions of care bundle. That's going to be used the PACIO Transitions of Care Implementation Guide. So I'm going to go ahead and jump into the Transitions of Care section and create a new Transitions of Care. So here, this is we'll give it a title, a Betsy Smith Johnson Transitions of Care document. This is coming from the emergency department where she currently is. The author is Dr. Priya Sarkar. This is a discharge summary. Now, this transitions of care document, is going to contain all of the information that's going to be relevant to her transition of care. So things like all of her allergies, all of the problems that she's experiencing, results and observations that have been collected. And then the key part for this particular demonstration, we're going to include medications. We're going to include the medication list that is associated with her in the emergency department. So we've selected the different sections we want to include. We can go ahead and create this transitions of care. Now that it's created, we would like to send a notification to that nursing facility, a discharge notification, basically saying, Betsy has information available. Here's a pointer to the transitions of care bundle we just created. So we're going to notify, and the organization that we're going to be notifying is the Motor City Skilled Nursing Facility. And note that this is a fire discharge notification message from the Da Vinci Unsolicited Notifications Implementation Guide. So this entire workflow is taking place using fire. We're going to send this discharge notification. And when receiving the notification, the SNF staff is going to query the EDEHR to obtain and pull that transitions of care bundle. They would then forward that discharge notification to the medication reconciliation solution for a pharmacist to complete a reconciliation and develop a medication action plan. During this demo, we're just showing the ED portion of these steps, creating the bundle and that initial discharge notification. We won't show those SNF steps, receiving and forwarding the discharge notification, since the focus of this vignette is on that medication reconciliation portion. So with that, I'm going to hand it back to Anne-Marie. Let me find where my screen share can be stopped. And now we'll see what happens once that discharge notification is received. Over to you, Anne-Marie.
Awesome. Thank you, Pete. So I just want to confirm you've gone ahead and sent a fresh bundle because I've cleared prior data.
I have indeed.
Gotcha. So we've started pulling the data. Right now I have nothing loaded for Betsy. I'm basically going to be running my queue and see who's ready for me to do any kind of new review. So I look at my roster, I'm running my poll, and of course now I'm looking to see, in fact, we have just loaded in, we see the work queue roster entry date. Based on our polling of the server, we're seeing that there's new data that's been loaded for Betsy as of these past few minutes. And we see in our work queue roster that we've got patients that, we may be overdue for a review, or we've got fresh data. So we're going to start working Betsy's care transition case for her deep dive medication reconciliation. So sort of the first new extension here that we've done with the PACIO fire integration is actually looking at this polling to capture admission, discharge, and transfer status information and freshness of data. So we're not only looking at it in terms of the clinical payload and the extension of the model, but we're using it as a workflow trigger as well. So we're going to select Betsy's record. And now I'm going to go from what was, I previously scrolled quickly by and showed a blank record, to a record that is now populated with a medication list. So let's step back and see what we see in this application. As noted, this is an instantiation of our commercial software that we are using for MedRex now. We capture demographic information on Betsy. We capture encounter metadata based on whether or not this is an admission or a discharge. So in fact, this is a discharge medication reconciliation and review. We can capture other information based on the use case about what kind of encounter this is that we're working, which may or may not be relevant depending on the use case. What we've also just pulled down from the server as part of that polling query I just sent out to the fire server is current allergy status. on angiotensin converting ACE inhibitor medications, and then also a robust condition list. When James was introducing Betsy as our sample patient, he listed the variety of issues that she's been challenged by, including some, conditional and functional status information here that's coming over in addition with our condition data. And then, of course, lastly, the medication list. So in conducting a medication reconciliation, of course, we would expect very robust data to be coming either with claims data or with EHR data. So for example, we would expect to see this frequency column populated. Given that we are working with the pseudo EHR, which is stood up as basically a test harness for exchanging and validating the FHIR bundles, we're also working with a subset of data more to validate the exchange mechanisms and not as fully populated as we would expect for a true clinical encounter. So we would expect frequency, we would expect SIG, we would expect very robust data with which to conduct our analyses. We would also be expecting in an actual commercial use case implementation to get multiple sets of data. So for our talking points today, we discussed that Betsy's in a discharge from acute care status. So this is what the acute organization has sent over to us for review. But as she's being admitted to the long-term care facility for additional support, we may have information from where she may have been in a prior encounter. We may have information that's been prescribed as of her intake to the facility. We may also have prior information on her functional landscape of medications at home, supplements she may be taking, things she's been on for ongoing management that she was taking at home that could have been captured either coming from a primary care or care coordinator encounter that came over from an HIE, could have been captured in a home visit by a visiting nurse or a home health aide or a visiting pharmacist, and documented and ingested into our system via a variety of different means. So in a fully validated use case, we would be expecting to see multiple columns of data. And again, as I mentioned earlier, harmonizing that across different coding schemas. So for example, we're getting in RxNorm information from the pseudo EHR. Other EHRs may likely also be coming in RxNorm, but we might be getting claims data from SureScripts in NDC, or if this was coming as a direct point-to-point from one Medispan-backed clinical system to ours, which is also Medispan backed, we could be getting GPI codes, which are the proprietary coding schema that Medispan also uses as an overlay to its GPI and RxNorm tables. So we've got a variety of different things. We would all present them on the same row, harmonized, so that the pharmacist doesn't have to correlate what's available in what setting. And then where there are gaps, that informs their assessment. Similarly, in terms of lossiness of the data, it's not just data availability, it's the content of the data. So of course we would expect frequency information, SIG information as well. We would expect additional context on the dosage, as well as we already have the dose form in terms of the route. We may be getting instructions and a variety of other things that are either riding along in a previously sent data bundle, or that may be captured if there is an interview or phone outreach or additional context, and we're maintaining it in a structured form to the best extent possible in a coded value or free text where only available. Similarly, if there's some record on internal commentary from the clinician or patient-facing instructions, notes about how the patient self-administered, that rides along. Putting context around the review, and then determining what kind of disposition is appropriate. So we can make edits and changes. So therefore, not only capturing the largest variety of data, but also getting the most richness of data in that deep dive review. So we're able to make those edits in the process of that medication reconciliation. But in terms of determining all dispositions and finalizing that review, we also want to look at it in terms of risks. So we're going to invoke our risk rules engine, which is applying a variety of different rule sets on this medication regimen, all the way from default drug-drug interaction, duplication of therapy embedded in the drug database, proprietary rule sets such as anticholinergic burden or high-risk meds for the elderly, formularies, quality measures around things like adherence, etc., or any other kinds of appropriately framed risk sets that would apply for a given use case. For the purposes of today's demonstration, I'm going to cherry pick a couple drug interaction risks and show how we would use those to document or define an action plan. That can be triggered from a risk. It can also be triggered from a medication or condition or allergy that's been selected from our landscape of clinical data. So I can trigger an action plan from a specified medication, or I can trigger an action plan from a clinical risk. So let's take a look at that, because as I described earlier, as we've been working with PACIO and extending our FHIR interfaces, but also really pushing hard against the boundaries of what the implementation guide documents for pharmacist-led interventions, we've had some really exciting developments around looking at how the action plan or actionable clinical recommendations really fits into pharmacist-led workflows. So here we've selected, just for the purposes again of this demonstration, a drug interaction where we've captured the medications that are involved, what the impact is. We've captured a little ride-along data and a date. We can define what kind of action plan category that is. So we've got, in this case, it's a drug interaction. We can define an appropriate intervention for this drug, an appropriate level of attention that may ride along with or be a draw of additional attention besides sort of the red, orange, yellow coding of high, medium, low risk. We really want somebody to take a look at the specific med for Betsy. We can define a recommended action and indicate that we may want to evaluate alternative. And so we have the recommendation that goes with that. If this is a case with an ambulatory patient, we want to put some documentation for the patient as well. We're able to capture that. All of that gets coded into the FHIR bundle in a structured way. And we can send that along. So we're going to save that. And I want to take a look at any other kinds of things that we want to fold into the reconciliation. And at the endpoint of that reconciliation, we're going to sign the reconciliation, i.e. we have validated this med list is complete. It's been annotated according to what's appropriate for this review. So we see here a time and date stamp that's been updated to support that. And now we're going to assemble the information and send it back for the prescriber or other providers to take appropriate action based on recommendation. So here we see the landscape of action plans, the one I just documented, also possibly also a prior, and I'm going to assemble that output bundle. And while we're doing this, we're assembling it in multiple parallel ways. I'm taking the newly created standard medication profile med list bundle. I'm also including the medication action plan when I assemble my final output summary. So to do that, I select one or more risks that I want to include in that package that's going back to the HIE or the EHR, in this case, the pseudo EHR. I assemble the output summary, and I'm co-assembling both a human readable format that can be read as a document, nicely formatted, appropriately structured, that can be pulled up and reviewed on a screen, but I am also sending it in the structured data format via FHIR for display into the clinical record or for redissemination back into an HIE. So now I'm selecting it for the parallel, quote, print-friendly format, but it's also including all of the appropriate subordinate components that go into the FHIR bundle. So we are assembling that result. Human-friendly version, as I'd mentioned, kind of looks like this. You got our triggers and our action plans, and we've got our qualified medication list that's been reviewed, any kind of recommendations and comments here, appropriate documentation. Now we're also going to send this back to the FHIR server. So at this point, I'm choosing to post the FHIR bundle, and it's back over to you, Pete.
Okay. So at this point, the provider has received that medication action plan that was just put together, and they can view and act on that in the context of their systems and processes. Today, we're just going to show it in a simple viewer so that we can confirm that it was received. So this isn't intended to be representative of an actual system. We just want to show that the information arrived. So this is that bundle. And we can see the two detected issues that Anne-Marie included. We can see the medication list with the complete set of medications. Of course, in an actual provider system, this display of structured data would be more actionable, more targeted to the use case, and included critical information like dosage and frequency. We can also see the attached document. That's that same print-friendly document that Anne-Marie was showing. And this is basically the end of the process, and you can picture how the structured nature of this data can facilitate a lot of important portions of the care for this patient. So that brings us to the end of this testing vignette. So hand it over to the floor for questions or comments. Thanks very much.